Welcome to the Talking Ketamine podcast, the show where we explore the science behind this fascinating molecule. This is episode 37, Ketamine and Liver Damage.
Thanks for joining us. Today we're discussing a serious potential complication, a form of liver and bile duct injury called sclerosing cholangitis, which seems to be linked in some cases to chronic recreational ketamine abuse.
That's our focus today. We've looked closely at source material centered on a new case series. It details two patients with this specific emerging condition, ketamine-induced sclerosing cholangitis.
That's right. And while physicians are, relatively familiar with ketamine causing bladder problems.
Yeah, that's fairly well documented now.
Exactly. But these severe liver and bile duct complications, the hepatobiliary ones, they're much less recognized. It's becoming a real clinical puzzle.
So our aim in this exploration is to figure out what the current evidence really suggests about this risk, especially, when ketamine is used recreationally at those high doses, and why this condition is, frankly, so worrying.
Absolutely. Given how potentially devastating this condition can be, understanding it is crucial.
Okay, so before we get into the specific cases from the source, let's just establish the basics. Can you explain sclerosing cholangitis, or SC, in simple terms? Why is it such a big deal?
Certainly. Think of sclerosing cholangitis as a progressive destruction of the liver's, its plumbing system, the bile ducts.
Okay.
It involves chronic inflammation, which then leads to fibrosis, that's severe scarring, and strictures, which are basically tight narrowings within the bile ducts, both the ones inside the liver, the intrahepatic, and the larger ones outside, the extrahepatic.
So the bile, the stuff the liver makes to process waste and help digestion, it gets stuck, backed up.
Precisely. That backup, bile stasis or cholestasis, is the core problem. If that flow is slowed down or stopped because the ducts are narrowing and scarring up, well, that damage can become permanent.
And the ultimate consequence.
If it keeps progressing, the really severe outcome is irreversible liver damage, specifically cirrhosis, which is extreme scarring of the liver itself. At that point, often a liver transplant is the only option.
Wow.
And that's why we see those particular lab markers jump. Gamma-glutamyltransferase, GGT, and alkaline phosphatase, AP. They rise significantly because they leak out from the damaged lining of those bile ducts. High levels are a direct signal something's wrong with the ducts.
Right, that makes sense. But here's the puzzle, isn't it? Ketamine is known for its effects on the brain-blocking NMDA receptors, causing dissociation. How does an anesthetic manage to damage the physical structure of the bile ducts?
Yeah, that's a fascinating question. And the honest answer is the exact mechanism isn't fully confirmed. It's suspected.
Okay.
The main hypothesis revolves around those same NMDA receptors. The theory is that these receptors aren't just in the brain. They're also found in the smooth muscle of the bile ducts themselves. So the idea is that ketamine blocking these peripheral receptors might cause issues like, say, sustained spasms, chronic irritation, or eventually those structural changes and scarring.
But hold on. If that's the case, shouldn't we see this kind of liver issue in anyone getting a standard dose of ketamine, like during surgery?
That's a really important point, and the sources address it directly. Other studies, ones looking specifically at single acute doses like giving ketamine to surgical patients, they found no significant effect on the motility of the sphincter ovati. That's the muscle-controlling bile flow into the intestine.
So one dose doesn't seem to do it.
Exactly. This strongly suggests the problem isn't tied to the immediate acute drug effect. Instead, it seems much more likely related to the sheer amount, the chronic nature of the use, and the repeated high-dose exposure typical of recreational abuse patterns.
So it's maybe less about the drug's direct action in one go, and more about the cumulative stress, perhaps toxic byproducts building up over a long time, causing this gradual, irreversible damage.
That is the prevailing theory, yes. That it takes sustained high concentrations over time to really create the conditions for that irreversible fibrotic damage in the duct walls.
Okay, let's turn to the two cases in the source material. We often hear about chronic ketamine abuse affecting younger men, particularly in reports from Asia. What was different about these two patients?
Well, right away, the demographics were unusual and quite significant for raising awareness. Both patients were European and both were female. One was 52, the other 24.
So definitely broadening the picture of who might be at risk.
Absolutely. It shows this isn't confined to one group.
And what about their clinical stories? Were they similar?
Both clearly had a history of chronic high-dose recreational ketamine use. However, case 2, the 24-year-old, her situation was significantly more complex due to polysubstance abuse.
Right.
She was also using cocaine, cannabis, and this is important, up to 4 grams of paracetamol, acetaminophen daily for several months. That really complicated the diagnostic picture.
4 grams daily, that's a lot of paracetamol. Did they come in complaining of liver pain or jaundice, or was it more subtle?
Often, the onset regarding specific liver symptoms is actually quite silent. They initially presented mainly because of those significantly abnormal liver function tests, the high GGT and ALP, indicating that cholestasis, the bile backup.
So the labs flagged the problem first.
Yes, but the sources highlighted a really key clinical correlation. Case 2, the younger patient who reported much more severe urinary symptoms, frequent urination, incontinence.
The bladder issues we mentioned earlier.
Exactly. She also had a significantly more deranged set of liver labs and more abnormalities seen on her bile duct imaging.
Interesting.
And this observation actually supports what's being seen in other case reviews now. The severity of the cholangitis, the bile duct inflammation, seems to track with the severity of the urinary symptoms.
That suggests a more systemic toxicity, maybe, affecting similar tissues in different organs.
It certainly points that way, perhaps affecting smooth muscle or lining tissues in both the urinary tract and the biliary system. It's a crucial link for clinicians to be aware of.
Definitely. Okay, so diagnosis. Given case 2 had multiple substances involved, and even case 1 had some complexities, how do they actually pin it down? Why wasn't it straightforward?
Well, one initial challenge was the imaging. The MRI results were variable. For case 1, the 52-year-old, her initial MRI was actually reported as normal. No obvious bile duct issues, despite her labs being very abnormal.
So normal scan doesn't mean you're in the clear.
Not at all. In contrast, case 2's MRI did show clear problems, variations in the duct width, some narrowing or stenosis of the main bile duct, plus inflammatory changes, findings that looked quite similar to primary sclerosing cholangitis, or PSC.
Okay, so if the imaging can be hit or miss, what's next? Biopsy.
Exactly. The liver biopsies were crucial. They provided the most concrete evidence. In both cases, the tissue samples showed damage consistent with sclerosing cholangitis, clear bile duct injury, inflammatory cells infiltrating, significant reaction in the smaller ducts.
But still, the diagnosis wasn't considered definitive, right? What was the main hurdle? Where did the medical detective work really come in?
The biggest hurdle was the differential diagnosis. They had to rule out other conditions that can look very similar. Primarily primary sclerosing cholangitis, PSC, which can arise without a known cause and also has a poor prognosis.
And microscopically, they can look the same.
They can look almost identical under the microscope, yes. The really key distinguishing factor, though, is that PSC is overwhelmingly associated with inflammatory bowel disease, IBD, like Crohn's or ulcerative colitis. Since neither of these patients showed any signs of IBD, that increased the confidence that ketamine, not spontaneous PSC, was the likely culprit. They also had to consider other potential toxic causes, like a possible drug-induced liver injury, DILI from an antibiotic in case 1, or definitely the paracetamol abuse in case 2.
So with all those potential confounders, other drugs, the PSC possibility would ultimately convince the physicians that ketamine was the main driver behind the serious damage. What was the key evidence?
It really rested on 3 main pillars. First, obviously, was the undeniable clinical history of chronic high-dose recreational ketamine abuse in both women. That sets the stage.
Okay, the history.
Second, and this was clinically very compelling, was the response when they stopped using ketamine. In both cases, as soon as ketamine was discontinued, even just temporarily in case 1, those cholestatic liver enzymes, the GGT and ALP, started to improve significantly. They began normalizing.
Wow. Seeing the severe lab results reversed just by removing the substance.
Yeah.
That's a powerful indicator.
It really is. It's probably the strongest piece of clinical evidence linking the two. Cause and effect in action, essentially.
Makes sense. And the third pillar?
Finally, they used a formal assessment tool called the Roussel-Uclaf Causality Assessment Method, or RUCAM score. It's specifically designed to assess the likelihood of drug-induced liver injury.
And how did ketamine score?
Despite all the complexities, like the polysubstance use, the score was calculated as +3 for ketamine in both patients. This categorizes the causality as possible.
Now, possible might not sound like slam-dunk certainty to a layperson. In the context of DILI and multiple drug use, what does a +3 really signify?
That's a fair point. When you have confounding factors like other drugs or potential underlying conditions, getting a higher score like probable or highly probable is often very difficult. A +3 or possible score in this messy clinical reality is often the highest a clinician can reasonably assign. It acknowledges they couldn't absolutely rule out every other factor, but the weight of evidence, the history, the biopsy findings, and especially that dramatic clinical improvement upon stopping the drug pointed very strongly towards ketamine being the primary trigger.
Okay, that clarifies the diagnostic reasoning. Let's shift to management. If a doctor suspects ketamine-induced sclerosing cholangitis today, what is the absolute number one most critical step?
The single most crucial action, the absolute first line of defense, is ensuring the patient immediately and permanently stops all ketamine use.
Non-negotiable.
Completely non-negotiable. Cessation is the only intervention currently known to potentially halt the progression towards irreversible damage like cirrhosis. It has to stop.
And what about trying to manage the damage that's already potentially been done to the bile ducts?
Right. Active management might involve treating symptoms, perhaps using medications aimed at reducing inflammation, although their effectiveness isn't fully established yet. In more severe cases, where those strictures, the narrowings, are really tight and causing significant problems like jaundice or infection, endoscopic procedures might be needed.
Like putting in stents.
Exactly. Inserting stents into the bile ducts to physically prop them open and maintain bile flow. But because these patients almost invariably have the associated bladder problems and obviously the underlying substance use disorder,
It needs a team approach.
absolutely essential. A comprehensive, multidisciplinary team is needed. Gastroenterologists managing the liver and ducts, urologists for the bladder issues, and crucially, psychiatrists or addiction specialists to support the patient in stopping ketamine use and managing withdrawal or cravings. And this whole situation really underscores a major gap in our knowledge. We desperately need more research, particularly long-term longitudinal studies. We need to follow these patients, often young adults, over time to truly understand how this disease progresses, its pathophysiology, and to develop solid evidence-based treatment guidelines beyond just case reports and series.
Okay, so let's summarize what this means for you, our listener. This analysis really reinforces that while it might still be considered relatively rare, chronic, high-dose recreational ketamine abuse carries the significant, potentially irreversible risk to the liver and bile ducts. It's not just the bladder.
That's right.
This sclerosing cholangitis is a severe progressive condition. It needs prompt clinical attention because that progression to cirrhosis is a very real possibility.
Absolutely. And the key takeaway for management is the absolute necessity of stopping ketamine use. Clinicians need to be vigilant, screening for these liver and bile duct problems, especially when they see patients with those known ketamine-related urinary symptoms. It highlights a truly tragic potential consequence of long-term, high-dose abuse, a path that could, devastatingly, lead to needing a liver transplant at a young age.
Really vital information. Thank you, as always, for walking us through the source material, and thank you for joining us for this exploration. We encourage you to continue seeking knowledge on this complex and evolving topic.